The slides and the presentation will be available after today's session. So if you'd like to receive a copy of that presentation, please go ahead and put your email address in the chat box. And then also feel free to introduce yourself in the chat box. There will be a question and answer session after the presentation. So feel free to drop any questions that you have in the chat box throughout the presentation. All right. This waiting room thing is definitely fun. I didn't think that I would have to keep pushing the button even after I said admit all, but we'll keep an eye on that as I continue to do an introduction to the speaker here. All right, so many of you on today's call know that cancer is the second leading cause of death in Wyoming, and Wyoming is ranked 50th in the nation for colorectal cancer screenings. Fortunately, there are more ways than ever before to prevent cancers and find them early, offering improved health outcomes. So the Wyoming Cancer Coalition published their newest 5-year cancer plan in March of this year, and colorectal cancer remains one of the priorities identified. One resource to help with colorectal cancer screenings is the Wyoming Cancer Program, which is housed within the Wyoming Department of Health. And this program provides reimbursements to Wyoming providers for breast, cervical, and colorectal cancer screenings to Wyoming residents who are uninsured or underinsured and at or below 250% of the federal poverty level. The program covers services such as mammograms, Pap tests, colonoscopies, and at-home stool-based testing options such as fit kits and Cologuard. For more information on the screening programs, we encourage you to visit the website at health.wyo.gov/cancer, and I will drop that link here in the chat box shortly. Now it is my pleasure to introduce today's speaker, Caitlin Sylvester. Caitlin is the Director of Programs and Partnerships for the National Colorectal Cancer Roundtable, which is a national coalition that is co-founded by the American Cancer Society and the Centers for Disease Control and Prevention. In this role, Caitlin provides strategic direction and support for programs and activities supporting the 80% in Every Community national campaign that is focused on increasing colorectal cancer screening rates to 80% nationwide. Prior to this role, she served as the Senior Manager for Cancer Control Strategic Partnerships in the South region of the American Cancer Society. Caitlin received her Master's in Public Administration and a Bachelor's of Science in Psychology from Louisiana State University, and currently serves on the Louisiana State University Department of Public Administration's Advisory Board. Caitlin is based in New Orleans and enjoys running, baking bread, and spending time with her husband and elderly dachshund. So without further ado, please help me welcome Caitlin.
Hi, everybody. Of course, the first issue I have is trying to figure out how to get off the mute. I'm so happy to be with you all today. And I'm really excited to learn from you as well. I would love to hear in the chat, what you guys are experiencing, what sort of barriers or opportunities you find. So throughout my presentation, if you'd like to put any thoughts, comments, questions in the chat, that would be wonderful. So let me share my screen. And we will get started. Okay, is that pulling up for everybody?
Yes, ma'am.
Wonderful. So again, yes, my name is Caitlin. I'm with the National Colorectal Cancer Roundtable. So today, what we're going to do is talk a little bit about NCCRT and our history, talk about screening guidelines and colorectal cancer screening data as we've been seeing it over the past couple of years, as well as the USPST screening guideline updates. So that's something that is obviously very exciting for ACS and NCCRT. We want to talk about challenges and opportunities, really understand the impacts of COVID-19 on CRC screenings and outcomes. And then I was really excited to share with you all new and upcoming resources that hopefully you can use to support your work. So as you just heard, NCCRT is a national coalition. We have partners from the public arena, private, volunteer organizations. Our membership includes doctors, physicians, researchers, as well as public health professionals, the ones implementing the work on the ground. We also like to incorporate our friends at ACS in all of our work to really help us with advocacy. And really our ultimate goal is to increase the use of proven colorectal cancer screening tests among the entire population. So you'll see at the bottom, we want to convene, identify those challenges and those opportunities, and then collaborate on ways to fix them. Again, we were founded in 1997 by ACS and CDC, and these are two of our strongest partners. So I am an American Cancer Society staff, so that's what American Cancer Society does. And then the CDC provides additional support to fund our projects, our research, and as well as bringing folks together in collaborative sessions. So right now we have 150 members as part of our organization, and we have our annual meeting, which hopefully you guys were able to attend last month. Usually it's in person. Unfortunately, this year was virtual, but it did allow us the opportunity to really open it up to everybody. All of the work that we do is driven through our 80% in every community strategic plan. We're actually really excited. We have an online version of this now, but this plan was really developed to carry us from 2020 through 2024 and help to guide our work. So the 4 areas that we decided to focus on was to catalyze our healthcare systems, mobilize public touch points. We really want to break down policy barriers, and you'll see big P, little p. So we want to do large state legislative work, as well as those internal policy changes. We call them like systems change. You know, what work can we do inside of a system to make it easier and to break down those barriers to screening? And then access and build capacity in communities. So I kind of come from a coalition background, and that's a great example of that. You know, state roundtables, local work groups, local coalitions. How can we encourage folks to work together to really tackle a lot of these problems? So as you know, I'm sure as many of us have, you know, we're used to having printouts and resources. With this strategic plan, unlike our other ones, we were able to create an interactive version online. So if you go to ncc.org/strategic plan, you'll go to explore it, you can highlight different areas and then see some of the work that's been linked to these priorities. So while the strategic plan drives our work, the groups that really help us implement it are strategic priority teams. Now, these used to be task groups, now they're strategic priority teams, which is less easy to say, but we'd like to think it's a little more functional. So if you guys do come from coalitions, sometimes it can be really hard to get folks to mobilize and work together. We form these groups around thought leaders. So how can they help us identify the challenges, bring in the right people to work on some of the issues, and really help us identify, you know, what areas do we need to focus on? So these are currently the ones we have identified. Some of them may sunset eventually. This is really made so that it can evolve. Community health centers, obviously a huge focus for NCCRT. Along with screening, we also focus on family history and early age onset so that folks know symptoms, what those tend to look like if you need to get screened earlier, if you do have a family history. We know that rates of colorectal cancer are rising in the under 45 population. So we want to let those know that, you know, who do have a family history or do need some extra focus from their medical professionals, that they have that information. Policy action, again, that drives a lot of our big P and little p work. Professional education and practice implementation, we gave that a jazzy name, we call it PEPI. And we have a group focused on communities as well as larger healthcare systems. And then public awareness and social media. You know, it's really important to get the word out, have people, you know, receive this information in a way that they can understand and then use. And then this is just to kind of help frame how NCCRT is structured. So you see at the top, our strategic plan. You'll then see our focus areas, which we went over earlier, and then our strategic priority teams. You can kind of see how they fall across those focus areas. We really try, you know, to cover everything. And while there is a little bit of overlap, I think it allows for better collaboration, you know, among these partners. When these groups identify needs, issues that maybe us, you know, at the top or at ACS we're not fully seeing, we're then able to pull together a smaller group as, you know, as an advisory group to help us work and conceptualize on what resources we need to create to help tackle these problems. So we'll contract with external vendors, and I'll share some examples of our research later in the presentation so you can kind of see what this looks like. So again, like a little different from task groups, where historically task groups kind of implement the work. Our strategic priority teams help us identify who those people need to be to join these advisory groups and these working groups to help us create those resources. So what makes a successful NCCRT activity? And I think this is a really nice overview for a lot of work that a lot of organizations do. We want to make sure it's collaborative. We want to make sure it's responsive and impactful. We want to make sure it's feasible. And equitability is a huge thing for us as well. It doesn't make sense for us to continue to focus on just one community. It's also really important that we don't duplicate or replicate existing work and other resources. We want to make sure it's member supportive. We are driven by our members, by our steering committee, and we want to make sure it's sustainable. Can this be used down the road? Another thing to mention is everything that we've done is fully free and fully available. If you go to our website, nothing is proprietary. We want this information to get out there and we want it to be utilized. So really, to answer the question of why NCCRT, why do we focus on colorectal cancer screening? Colorectal cancer screening is the second leading cause of cancer death in the United States when men and women are combined. So nearly 150,000 people a year are diagnosed, nearly 53,000 deaths per year. And what we're finding is that, unfortunately, 1 in 3 of those eligible aren't getting screened. What's especially interesting about it is a lot of the folks who have Medicare. So when you turn 65, you're eligible for Medicare. You can, either get a supplemental plan or a Medicare Advantage plan if you like. Medicare rates are actually really high when you look at colorectal cancer screening. But what does that say to us? It says that people 45, 50 until 45 kicks in, 50 to 64, they're not getting screened as often as they need to be, or they're delaying screening a couple of years or maybe a decade compared to what our recommendations are. So that lessens the chance of finding precancers that can be removed to prevent cancer, and also finding cancer when it's early and most likely to be treatable. So just keep that in mind. That's another priority for us. It's not that you get screened within this age range, it's that you get screened on time. And this is just to highlight the screening test that we recommend. Now, we never endorse a specific product, but you'll see on the left, we have our stool test, or our FIT, our FOBT, as well as the multi-target stool DNA, most often known as Cologuard. They have a really great marketing campaign, so I'm sure everybody's seen those commercials. And then on the right side, you'll see those visual tests. So that's going to be a colonoscopy, CT colonography, and flexible SIG. While we don't endorse, and there used to be kind of this notion that the colonoscopy was a gold standard because you could remove polyps and you could find cancer when it's early. We really promote that the best test is the test that gets done. And what we're finding from our partners and our members, a multi-pronged approach is really the one that shows the most success. So that can be maybe a Fit First campaign. With that, you just want to make sure that follow-up colonoscopy is available. So I want to talk a little bit about our progress. So our goal for NCCRT is having an 80% screening rate for the eligible population. In 2014, we were tasked with creating a bold goal. At that point, we'd been around, over 10 years, 17 years. What are we doing? What are we really pushing ourselves to accomplish? And what our steering committee dedicated themselves to is reaching an 80% screening rate by 2018. And this is across the United States. So ACS really took that on as a priority. CDC also championed this work. And what was exciting is that we were able to screen 9.5 million people, additional to what was anticipated in those 4 years. Unfortunately, we didn't hit 80%. I think maybe a state or two did. Louisiana didn't, I can say that for sure. And it really allowed NCCRT to do a bit of a refocus. We know that if everyone with insurance gets screened, then we would hit 80%, and that would be, a nice little checkbox. But what happens when you do that? You miss out on those communities that face inequities, you miss out on opportunities to reach out to new populations, to understand challenges that different populations are facing. And those inequities tend to just build greater if we only focus on the folks that have insurance. So that's why we pivoted and created the 80% in every community campaign. And what this campaign really champions is an 80% screening rate in every community. And that's community defined as you define it. So it can be the state of Wyoming, it can be a specific town, a region of the United States, it can be a church group. You know, we want to make sure that everybody in every community can reach an 80% screening rate. So we have a pledge campaign where your organization can pledge to commit to the 80% in every community campaign. We have health centers, cancer centers, hospital and health systems, several state coalitions, comprehensive cancer coalitions, health plans, employers, and so many more. What is nice is we started getting elected officials, and they would help promote the work inside their states as well. And we've seen a lot of success. So every year we have an awards ceremony where we seek nominations, and then we really want to highlight and reward those that, you know, maybe they've reached an 80% screening rate, or they're doing really cool, innovative work to try to reach 80%. We like to share those findings. We like to make sure that those tools and techniques are available to everybody. So while we've had a lot of progress, there's still too many communities with too low of colorectal cancer screening rates. So, and you know, on this map, you can kind of see these UDS rates. It's obviously not, you know, the same across the board in the United States. So our mission will not be achieved until we reach an 80% screening rate or higher in every community. Coming out of the 2021 annual meeting, NCCRT did establish several new priorities. We want on-time screening, like I was mentioning earlier, as soon as you're eligible, whether you're at average or increased risk. Timely colonoscopy to abnormal stool tests. So if you do an at-home test, we want to make sure that you can get that colonoscopy as soon as possible, and there's not going to be, you know, a 9-month delay or something like that. And then really addressing, but understanding the sources of disparity. So not just kind of using our knee-jerk reactions of what we think the problems might be, but really talking to those communities, talking to those experts, and using it as a time to really learn as much as we can so that we can have the right resources and people in place to guide our work. And this will most likely be our focus over the next year or two. So before we move on, I would love to hear from you guys. So if you wouldn't mind, in the chat box, I would what sort of barriers are you seeing to colorectal cancer screening? Is it a priority to your organization? And if so, you know, what does that look like moving forward? Is it something that will remain a priority, or do you see kind of shifting tides? It's always helpful for me to hear from other states, other parts of the country, so that I can bring that back to my colleagues and my steering committee members and really show them, you know, what we're hearing from the field. So, and before I move on, are there any questions? Would anybody like to come off of mute and ask a question? Okay, I can't see the chat box. So if there is anything in the chat, let me know, but we'll go ahead and move on. I wanted to talk a bit about our screening rates and the updates to the USPSTF guidelines. So preface, behavioral risk factor, screening rate. So this is, you know, a phone interview. It's self-reported. So I think we all take it with a grain of salt, but we like it because it's apples to apples per state. You can see over the past 9 years, rates have really crept up, and it's been really exciting. And we were excited about the jump we saw after the 80 by 18 campaign. It was really encouraging to see those rates continue to climb. You know, there were other factors. Obviously, some states have Medicaid expansion. We can assume that maybe helped with the rise, but it really became this national effort to increase those screening rates. You'll see our HEDIS measures, and these come from Medicare and commercial plans. So up until COVID, we were seeing these really exciting gains in the screening rate for commercial plans. but then you started to see them plateau over the years. Screening rate for Medicare plans wasn't available in 2019 because of COVID. So CMS suspended the quality reporting requirements, and it kind of gives us a bit of a gap of information. But one thing to take away from this slide is, like we were talking earlier, what age are people getting screened for colorectal cancer? Medicare is for folks generally 65 and older. So you can see how much higher their rates are. So commercial plans with those, people 50 to 64, we're not seeing the same level of screening rate. And so that's something to kind of consider and keep in mind. If you do work with health plans, or if you do work with general population folks who are insured, if they have insurance, are they getting screened? UDS screening rates come from our federally qualified health center partners. And HRSA reported an overall colorectal cancer screening rate in 2020 of 40.1%, which demonstrates a 10% increase since HRSA, the folks that track this, began tracking colorectal cancer screening as a UDS measure in 2012. So something to really celebrate. Unfortunately, that rate is down from 2019, where we saw 45.6%. It basically wiped out 5 years of progress. And it's really just a reflection of the myriad of challenges that health centers faced due to COVID-19. Despite these challenges, health centers still screened 2.5 million people in 2020. That's phenomenal. Unfortunately, screening that many people doesn't really make up for the gap that was missed. We would expect to see those rates higher if we were, getting everybody back on track. So just kind of highlights a bit of that delay and a bit of why this is still such a priority for us. Now, I wanted to talk about the USPST guideline changes. Now, ACS updated our guidelines in 2018. 2018 was a big year for us as far as colorectal cancer is concerned. And, after overwhelming research, we used different modeling, we were confident in making the recommendation that everybody, average risk, so you don't have, any symptoms, you don't have a family history, should begin screening at 45. What was very exciting is that this past year, the Preventative Task Force, which health plans, unless grandfathered, they must follow these recommendations, agreed with our recommendations. They also said 45. When you get to 75, it really becomes a shared decision-making process with you and your doctor. But what we really try to focus on is at 45 to 75, what can we do to get you screened? And then you'll see the acceptable test options. So generally our recommended tests line up as well. One thing to keep in mind is that there is a lag before health plans need or have to implement this. They're given time to update their systems, update their strategies, and really set themselves up to start incorporating this into all of their plans. Now, some have voluntarily adopted this before they're required to. Some were screening at 45 before these recommendations came out. What we're seeing is that health systems are really excited about 45 and they want their patients to get screened, but they're not yet covered to get screened at 45. Some states are working with their legislator to get this updated beforehand or have already done that. But it's an ongoing conversation that we are having with health plans, trying to be respectful, but really trying to move the marble as soon as we possibly can. To do a bit of a deeper dive into COVID, we saw the rates previously, what some of those effects were. So across the board, rates of breast, colorectal, and cervical cancer screenings decreased severely, and colonoscopies were down by 90%. People were afraid to go see their doctor. People reported being anxious and scared. And because of new safety procedures, there was really this time, that was dedicated to prepping, cleaning, that took away from being able to perform as many screenings. Our fear is that this could continue to threaten our progress and really delay diagnosis, and we'll start to find late stage cancers. And here's a really great visual of our screening rates dropping in 2020. And they were swift and very dramatic. So you can see them kind of represented in that middle piece of the graph, and you see an immediate 90% drop. And that's the first week of April, I believe. So as the numbers of cancer screenings begin to rise, they still haven't reached that expected level. We've also seen a 94% drop in newly diagnosed cases of colorectal cancer, and that's not due to missed screenings, but also delays in symptomatic cancers. So if folks are experiencing symptoms, that goes in some of that anxiety of going to a healthcare center, putting off seeking medical attention. And this is really our greatest fear, excessive deaths from colorectal and breast cancer due to these delays in screening. So this came out in the summer of 2020. They're already making these predictions that we could see 45 extra deaths by 2030 due to these delays in screening and prognosis. But what are we trying to do to combat this? So NCCRT and ACS created our Return to Screening campaign. And with that, we created the COVID-19 pandemic playbook. So it's action-oriented, and it really covers what different types of organizations can do. It's available on our website. So again, or anyone from ACS can send you this resource, but it reviews the data, the research, the clinical guidelines, there's maps, and there's also, sample letters, sample communications that, again, are available, they're free, we're happy to share them. Before we go into resources, any questions in the meantime?
Not seeing any pop up on the chat box yet.
Okay, and feel free to come off of mute. So our NCCRT resources, we have a lot, so I'm going to try to make this not dense and boring, but we'll probably move through these pretty quickly. But again, just know we have a lot and we want to get it in your hands. So first stop is our resource center. Unfortunately, you can Google it and it'll take you back to stuff from 2007, but some of it is actually still relevant, and we like to have those available. NCCRT also puts on a lot of webinars. You can see links to all those webinars, and oftentimes the PowerPoint presentations that go with them. We also have a really exciting data and progress webpage that provides up-to-date statistics on colorectal cancer screening, incidence, mortality, and geographic distribution information. This kind of gets into a little bit of a nerd zone, but I don't know if any of you guys have ever been to the American Cancer Society Cancer Statistics Center. So it's broken down by cancer, it's broken down by state. Tina, I saw Tina smirk. I was a huge fan of it. Continue to look at it, but it's a really great way to see a breakdown of your state and what it's looking like, screening rates versus incidence and mortality, and then maybe some of those preceding factors. Quick overview, we've really tried to gear our resources to every type of organization and every type of community. So just keep in mind that if we don't have it yet, we're probably looking at trying to create something for you. This year, we launched our Learning Center. And this was really exciting for us because it features two things. One is a colonoscopy needs calculator. And I encourage you to go on and play around. This calculator is for federally qualified health centers to estimate if they do a fit first campaign. So we're going to start with doing at-home stool tests. It helps them calculate how many colonoscopies could be needed. And again, that's to kind of prevent that lag into follow-up screening if you do get a positive fit or FOBT. We also have our communications education portal. And we're going to go into our market research a little bit later, but this is where you're going to see all of that market research broken down. You have room to take notes. You can create your own profile and really explore past and present market research that we've done. And again, this has been, verified. It's not just kind of our knee-jerk reactions or beliefs. We really try to put in the effort to make sure this stuff is accurate for everyone. Our steps guide. I think this is one of our most popular resources. I want to say it's the most downloaded. This is for health centers on how to implement a CRC screening program and to help reduce physician workload and really get those rates up. So it provides guidance on conducting baseline screening rates, assessing capacity, and then really preparing your team. So it highlights what each team member, what their role is and how they can contribute to this initiative. We also have examples from the field, we have templates, and we have tools. This is also connected to a virtual interactive platform, so a lot of this can be downloaded and really easy to share. What's exciting is we're updating it this year. So originally this was just for federally qualified health centers. We heard from our folks in the field, all primary care was taking interest in this. And when it was just FQHCs, we were kind of missing a big portion of the population. So we've updated it, we're sharing new examples from the field, and we're really excited to get this released, hopefully in the next couple of weeks. We also have a health plan handbook. If any of you folks are from health plans or work with health plans, here's some of our best practices on what health plans can do to increase screening rates. Similar with hospitals, what can hospitals do? It includes 12 critical steps, 12 case studies, lessons learned, example templates, and helpful tools. We really try to highlight the good, the bad, and the ugly. I don't think it's ever helpful when you're like, oh, we wanted to increase our screening rates, yada, 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 and now we're at 80%. A lot of these case studies will highlight the challenges. They'll talk about what they still need to work on, and then where they're focusing moving forward. We have a clinical reference, which is a toolkit for primary care physicians. So this is quite extensive, and it really highlights the value of stool-based testing. But again, let's make sure we have that follow-up available. And then we have our tested market research. So we talked about that in the communications portal. If anybody remembers, in 2015, NCCRT released the communications toolkit. And it was kind of the first time it was broken down by population type. So there was the unworried well, I think the procrastinators, the avoiders, but it really dug into why people are not getting screened. And it's not that they didn't know, we've realized that that's not actually what the issue is. Since 2015, we've been expanding on that. So we started breaking it down by specific populations. So you see Asian Americans in colorectal cancer screening. We looked at Hispanics and Latinx communities. And that really culminated in updating that guidebook for the 2019 screening messaging guidebook. And this shares all of those market research findings and pulls out some of those priority populations as well. It also gives examples of what some of those crafted and tested messages were. So what we do is we usually start with a broad-based survey for people to fill out, what are their thoughts on screening, why aren't they screened, things like that. We'll do some in-depth interviews. From there, we'll work with our advisory committee to create crafted messages. And then we test those. We find out from people what resonated, what didn't, and why. I didn't like this message because, I don't know, it sounded snarky, or I didn't like this message because it was scary. I liked this message because I learned that it is important to know your family history. So what's nice about this is you really kind of see the why and the what if as well. So it's not just, again, assuming that we know what's right, but really trying to show how we got there. Risk assessment and screening toolkit. So this is really for detecting familial, hereditary, and early onset colorectal cancer. Again, those rates are increasing. And this toolkit is really helpful for that. We worked with experts to pull in, guidance on how to ask for family history, and then how to use that information. And it also has an algorithm in a flowchart format for providers. So, what do you do through this process? And we've heard feedback that this has been really helpful for a lot of systems. We have our patient navigator toolkit, which came out, I think last year or the year before, which we're really excited about. And this is specifically focused on patient navigators. We have a toolkit for evaluation, everybody's favorite. But it's really important to look at what you've been doing and, if it's been successful and why. If it hasn't, why didn't it work? And if it did, why was it successful? And how do we share that those successes with other folks? What we're looking forward to getting out there is our improving screening rates for state Medicaid agencies. So you can see how we're really trying to drill down on every organization type that touches colorectal cancer screening. And then what can comprehensive cancer coalitions do to advance 80% every community? We have another toolkit on, CRC roundtables and CRC working groups and things like that. We have specific case studies from every state. And again, all of this is available online. And then we'll soon be releasing, again, our updated steps guide and then new market research. So these are ones that I'm really excited about. Early messaging to reach the soon to be eligible, so like those folks who are 45, and to help inform people who might have a family history or might experience symptoms that they may need to talk to their doctor and see if screening earlier is right for them. We also have market research that we're actually working right now to put it into a resource to get it out to you guys on Black and African American populations, and really focusing on messaging to the unscreened. And then additional, just 80% every community resources. We continuously are trying to work with the 80 by 18 resources and get those updated for 80% every community. Make sure that there's that equity component built in. So how to get involved? Follow us on Twitter. I think we love the hashtag 80% in every community. We have a really great newsletter, CRC News, that goes out pretty often, I would say weekly, if not bi-weekly. We like to share, not just from our own organization, but what our partner organizations are doing, special days, areas for collaboration. We like to get feedback. You can take the pledge, and also you can apply for NCCRT membership. All that can be done on our website. So that is all I have. And thank you guys so much. I would really like to hear from you. What are your thoughts? What are you guys seeing? And what questions do you have?
Can you hear me?
Yes.
I just had a quick question. I had two family members that are over the age of 50 that recently went into their PCP to get a referral to go get a colonoscopy, and both of them were told that they could do the color card testing instead of the colonoscopy. And I found that, of course I argued, but I want them to do the color guard, but I found it to be really odd. I mean, I was glad they're getting tested regardless, but I just said, well, that's just kind of a baseline. And if you're over the age of 50, I'd still recommend that you get a colonoscopy, but both of them sent them straight to Cologuard. Is that common for providers to now just refer them to the home test kits, or?
That's a really great question. And I think it's dependent on, the system or the clinic. But what we did see in 2020 was a lot of physicians and systems were starting with that, we call it fit first, but really it's that stool-based first approach. And that was to help clear up some of the backlog. So if we can get people to do these at-home tests first, then we'll see if we need colonoscopies. Because what we also started seeing was a medical staff shortage. So people are retiring, people are changing positions or becoming travel nurses. And so the capacity just wasn't there anymore. So like you said, I think it's up to your discretion. Cologuard is a recommended test. It is every 3 years, so that's something to keep in mind. And it's, it's not going to be able to remove a polyp for you. But the research shows that it is a good test. But, you also have the freedom to have those conversations if your family members have those conversations with their doctors if they think colonoscopy is the route that they want to go. But just a real quick example. So Kaiser Permanente in California, they have been doing a fit first approach for years. So a lot of their members can't even start off with a colonoscopy, they go fit first.
Thank you.
Hi, this is Val Knapp. I'm one of the program nurses for the Wyoming Cancer Program, and I would definitely agree with, providing fit kits or Cologuards for patients as a first test, just because there are I talk to so many people that they don't want to do a colonoscopy. Like, no matter what you say to them, they don't want to do it. They don't want to go through the prep. They're afraid of, the invasiveness of the colonoscopy. And so if you can offer them a fit test or a Cologuard, I think that's a really great option, because then they are going to at least screen. and then they can move forward with the colonoscopy if, you know, that test does come back positive. So I think it really is a great option. I mean, it's definitely not for everyone. It's, you know, for people who are not at high risk, and we do explain that to our clients. But I think that option is getting more people screened, and I just think it's good if offices are offering that, other than just going straight to colonoscopy for a lot of people.
Yeah, it was actually my husband, and I wanted him to get the colonoscopy just so he had the experience. But he actually was at his the surgeon's office, so the PCP didn't even refer him. He was going into the consult, and that provider recommended that he do the Cologuard, which I thought was odd because he was already in for the consult for the surgery. So I just was curious to see what the statistics are. I mean, I agree, like Star said, any test is better. I mean, get it done no matter what, either way. So I just found it to be odd. So that he was already in there for the consult, and they said, no, we're not going to do a colonoscopy today.
Oh, wow, that is really interesting. But yeah, so, you know, over the years, we have seen the use of at-home tests increasing. And one thing that the people that we're hearing that folks really like is that Cologuard has that built-in kind of patient navigation. So they'll follow up if you haven't returned it. They'll follow up if you might need a follow-up colonoscopy after talking to your doctor first. So I haven't heard of that before. You're going in for colonoscopy and they kind of switched gears on you, but maybe that was a capacity issue at that surgical center. I'm not sure.
Thank you.
And Lauren, I'm seeing your question in the chat. So does Cologuard detect adenomatous polyps? I don't know off the top of my head, but we can definitely find out for you. And I know there's a lot of literature on it, specifically what each test does. So we can be sure to find out. I just can't remember off the top of my head. Any other questions or comments people have?
This is Val. Sorry, I was on mute, I guess. I just wanted to point out that I still talk to people who still give the reason of COVID as, you know, a reason why they still aren't getting screened, which I found pretty interesting. You know, they're kind of staying away from the hospitals and the surgical centers because they're still afraid of COVID, and they want to wait until it's, you know, more under control, I guess. But I just thought that was interesting that those statistics are still out there, even, you know, a year and a half later.
Yeah, and that's it's disappointing to hear that it's understandable, but it's a reason why it's a priority for us for people to get back to screening, and that's across the American Cancer Society. Really, we were calling it return to screening, but you know, it's going to continue to grow and evolve.
Yeah, it's unfortunate.
Any other questions before we wrap up?
I don't see anything else coming in.
Well, thank you guys so much. This was really fun for me, and I'm always excited to share what NCCRT has. If you guys do have any questions, my email is my name. It's CaitlinSylvester@cancer.org, or we have NCCRT at cancer.org. Please feel free to reach out to us with any questions. And again, explore the website. Let us know what you think, and let us know you know, where you're seeing gaps and what we should start to focus as far as new resources. But again, yeah, thank you guys so much for having me. This was a lot of fun.
Thank you again for joining us today. So